Welcome to Beyond the Wheeze, the podcast where perseverance meets potential. I'm Josh Realm, public speaker, marathon runner, asthma advocate, and your host as we explore the intersection of health, fitness, and resilience. Whether you're managing asthma, chasing a new personal best, or simply looking for inspiration, Beyond the Wheeze is here to show you that no challenge is too great to overcome. Together, we'll uncover stories, insights, and strategies to help you push beyond your limits. It's time to breathe deeply, move forward, and unlock your true potential, one step at a time.
Asthma isn't just about managing symptoms. It's about ensuring people have access to the right care, treatments, and support system to live full, active lives. Today's guest is someone who has dedicated her career to improving respiratory health and pushing the boundaries of what we know about asthma management. Dr. Mika Nonoyama is a leading researcher and clinician specializing in cardio-respiratory health, and she's an associate professor at Ontario Tech University and a registered respiratory therapist at the Hospital for Sick Children. Her research focuses on improving care for individuals with chronic respiratory conditions from a hospital setting to home-based rehabilitation programs. With years of experience in both academia and clinical practice, Dr. Nonoyama is at the forefront of shaping the future of respiratory care in Canada. She's working to bridge the gaps between research and real-world treatment, ensuring that the latest advancements translate into better outcomes for patients. Today, we're diving into her work, the evolving landscape of respiratory therapy, and what the future holds for asthma care. If you're an asthma patient, caregiver, or healthcare professional, this is a conversation you won't want to miss. With all that being said, Dr. Nonoyama, thank you so much for joining and welcome to Beyond the Wheeze.
Thank you very much, Josh. Happy to be here.
So happy to have you on. And we met end of January, I believe, at a conference. And then we touched base the following week at a panel discussion that we had, Bridging the Gaps in Ontario in respiratory care. And it was just so great to talk to you. And just the conversation was amazing. And I wanted to keep it going. I'm so fortunate to have you here. And I think our listeners are going to get some really valuable information from your insights.
Yeah, me too.
With that being said, we'll jump right into it. I know you're busy. So let's start off a little bit with your personal journey. So you've dedicated your career to improving care for individuals with chronic respiratory conditions. What sparked your interest in that field?
So it's a combination of things. Sort of earlier on in my career, I had the opportunity to work with dynamic people practicing and leading research in the field, including Dr. Dina Brooks, she's a physiotherapist, and Rob Bryan, a fellow RT. They were doing sort of innovative work, particularly for individuals with COPD or chronic obstructive pulmonary disease. But once I started in the research, I was amazed by the people who actually took part in studies. So the people with the chronic lung disease. A lot of the research I do is longer term research. So I would often see people multiple times throughout the study. And during the time, I was doing the initial research, I would visit people in their homes multiple times. So I could see the struggles and the triumphs of how research could make a difference within their lifetime. And that's what motivated me. It still motivates me, actually.
Well, you certainly have a unique perspective. Both as a researcher and a clinician. And how does that combination really shape your approach to patient care?
Oh, and it's so important. I wouldn't be doing what I'm doing if I didn't have the combination of the two. The research I lead or collaborate with always has some kind of applicability element to it. So either the ideas come from people with lived experience like yourself, healthcare providers, especially RTs or respiratory therapists, the local practice environment, and the organizations that advocate. So that researcher hat and that clinician hat, the research wouldn't be possible from, creating it and then doing it and then applying it back into practice, or the local environment. So for example, I took part in a study looking at the use of asthma biologics for severe asthma at the Hospital for Sick Children with Dr. Shirley Quash and Dr. Teresa Toe taking the leads on that. So the idea came from the fact that there isn't a lot of information or research on the use of those medications, particularly in children. And, Sick Kids is probably the largest pediatric hospital in the country. And so we knew that some of those answers, at least initially, were in that electronic health record, the medical records of these children. So in order for us to get that information, we needed researchers, so someone who has expertise in large databases. So that was Dr. Toe, along with the clinicians involved in the care of these children day to day. So the respiratory therapists, the respirologists, and then myself as well. So we needed that support from, the organizations that individuals with asthma, the ones that advocate for individuals with asthma as well, so they could get the word out to people with asthmas too, with respect to the research. And because of that, they actually provided the funding for this research. So the Canadian Lung Association worked together with the Lung Health Foundation and Asthma Canada to actually fund that research. So that's just an example of how you need the researcher hat and the clinician hat to make those kind of things happen.
That really outlines the importance of non-for-profits such as Asthma Canada, Lung Health Foundation. They're huge. And that's essentially why I advocate for people to really recognize these non-for-profits and help them out, because you're proof that this funding really does go a long way.
Oh, yeah, absolutely. Absolutely.
What's one of the most rewarding aspects of your work?
I would say, sort of we're going to have a common theme throughout our conversation, but definitely collaborating with and learning from the individuals with the lived experience, the clinicians, and everyone involved in the practice to research to practice process. Is always sort of a cyclical process. I'm always amazed at the level of innovation in respiratory research, despite the lack of funding opportunities out there. Mm-hmm. Like respiratory and lung health research is really underfunded given the amount of people who have chronic lung disease, not just asthma. Never mind just asthma, but it compared to other chronic diseases, which are important, but is very underfunded. So we get very creative with that limited funds. I've been lucky to work with amazing people who are willing to go outside their comfort zones to contribute. And that kind of motivates me. And in a way, I wish I had 3 of myself so I could work with everybody. But the good news is, when you sort of encounter a wall or delays or something, I know I'm in good company, both from an empathetic sounding board kind of thing, and also for providing sort of actionable solutions as well. That kind of helps as well. Yeah.
Yeah, it sounds like it really does take a village. And for the record, I wish we had 3 of you as well. I wish the resources were there, and I hope someday that they're more available, I guess you could say. Asthma care has evolved significantly over the years. From your perspective, what are the biggest advancements we've seen in treatment and management? And I would like to point out, too, that we kind of discussed this a little bit at our panel discussion back in January, kind of revolving around AI and what AI might look like in terms of respiratory management in the future.
Yeah. So I guess the first thought I comes to my mind isn't really so much advancement as what needs to be done for success. So first, I would say, before I touch on the AI aspect, is that amalgamation of asthma care with policy and public funding. So the primary care asthma program, or PCAP, has made leaps with respect to their programming and everything like that, because they're supported by the Ontario Ministry of Health and Long-Term Care and the Lung Health Foundation as an advocacy body. Because, as well, a lot of the people, the first place to go is primary care, their family doctor, right? So, the fact that they have dedicated funding and a process for that is great. So they're able to come up with novel practices, but also give it in a consistent way across the province. So it isn't like, well, you have a program there and you have a program there, and I don't have a program up here, so I'm going to reinvent the wheel because I didn't know that those 2 other programs exist. So it ends up being more consistent because it's under the guise of the government. And that's not just medications, it's management, action plans, all that sort of stuff as well. And And then when it comes to the AI issue, yeah, I definitely think I could see it. It's kind of like the issue of the precision medicine. So, AI is only as good as what you put into it. So it's, as time goes on and it's getting more and more good information, then it's going to become better and better. So I could see it being something where, there always has to be a human aspect to it so that they're contributing to it and during it and afterwards. So, research works in the same way. But I could see once it, maybe in a few years' time, because I don't think it's quite there yet, it'll be able to provide almost like, okay, so, Josh, this is your history. These are your triggers. This is your, where you live and everything. And you're able to put that all in there. And then maybe it'll come up with sort of a menu of different strategies, individualized strategies that could be, presented based on where you live or what have you, right? Because everyone has different resources and things like that. So that I can see happening with respect to advancements there. And then, of course, there's, I think I mentioned it before, the biologics as well. I think, there's, and other pharmaceuticals, they're becoming, they last longer. They help with prevention. So there's less use for rescue inhalers and things like that. Because pharmaceutical companies, they have the resources for research and development. So they tend to come up with these things a lot faster. But I could see that also continuing because that's always sort of been there.
Unfortunately, gaps still exist, and they're still going to exist for a while. A couple I can think of right now, and again, going back to speaking about AI, something that maybe potentially AI could help with right now. Biggest gap I can think of is lack of spirometry testing or lack of access to spirometry testing.
Right.
And decreasing the time that it takes to speak to a specialist as well. And as he pointed out, based on where you live, really your access to the resources differ. I'm in Northern Ontario, so for me to have access to a respiratory specialist, it might take me 6 months and I might have to travel down to Barrie. And that's at best, right? It could take me a year and a half to talk to my respiratory specialist. That's a problem. I don't think AI is going to be able to close that gap, but certainly in the realm of spirometry testing, I think that it could help to find improvements, which is terrific. And I do hope we see that. Despite these advancements, what are some of the most pressing challenges that asthma patients face today?
I'd say that there's always going to be question marks on the resources and funding and programs available, including, for medications and stuff like that. Asthma management plays into this as well. We've already seen the impact of different political environments. Just in Ontario alone in the last month, we had a provincial election, and now we're about to have a federal election, and never mind what's going on in, the states at the moment. So when the political environment changes, things tend to change because it's a different party or what have you. So I think it's important that when asthma management, that it is important enough that it's a nonpartisan issue, that it's like no matter who's in power or what have you, that they say, oh yeah, that's important. We are definitely going to support that regardless if they're whatever party they're in. And that would include research funding as well. But I think the other issue, and I completely agree with you, Josh, with respect to the spirometry issue, I'm actually taking part in a study they're doing in British Columbia at the moment. And what they're doing is they're trying to figure out ways to increase access to spirometry, particularly in the rural and Indigenous communities in British Columbia. So it's like a huge multi-year project. We're talking 5 years, and they're like a year into it, trying to research. The grant is a unique one because they need to produce strategies which are actually being done in the community at the time. So it's going to be interesting. Right now, we're at the point of what are the gaps and what's the research out there? And I have to tell you right now, there's not a lot with respect to how to increase access to spirometry. People have ideas, but it's not like a big eureka moment. But yeah, that is definitely an issue, which is why, the researchers led by Dr. Pat Camp did this in the first place. And there's a lot of dynamic people on that project. Oh boy. And then I think the other issue, which I don't think would surprise you, is climate change. I think that's a pressing issue that impacts anybody who has lung disease. It would be nice to figure out what can we do sort of in the short and the long term. So even if we figured out a way to preserve the climate, it's not going to happen tomorrow. It probably would take years before that might happen. And in the meantime, we just can't tell people to say, oh, you know what, you have lung disease. Oh, it's a bad weather day. Stay inside. Don't do anything. I mean, these weather days are becoming more and more frequent. And I don't think we can expect people to just stay indoors to do nothing. So I think there needs to be strategies or something to come up with to allow people to go out, whether it be technology or management or breathing techniques or whatever. So I think that also will become really important moving forward.
I agree. And just to go back to what you said, we are having those discussions in regards to spirometry testing. I'm not even in your circle or, your line of work. And I must have been to 5 webinars and or workshops over the course of the last year that discussed this issue. So it seems like there's a lot of possible solutions that are kind of being thrown about, but we're just not really getting there yet, unfortunately. But I mean, conversation is really the building block to change. So I do hope that it leads somewhere soon.
Yeah. It's and knowing the political landscape of how the health systems work, I think that's like a big, huge hurdle to go through. Yeah.
Yeah. And in regards to the climate change too, this time of year is horrible on my lungs, and I'm not the only one. A lot of asthmatics have that, where the rapid change or even the slow change, just that constant from cold to hot or from hot to cold, it really does impact me. And when I go traveling places like Louisiana, I was there a few years ago, just before COVID, and as well Mexico, I really have to worry. I really have to think about these things, especially if I'm going in the winter time, because that's a shock to my lungs. That's a shock to my system. And I have severe asthma. Maybe somebody without severe asthma won't quite notice it yet. But what happens when climate change really accelerates? It's scary to think about that prospect.
Yeah. No, absolutely. And I'm hoping to do a little bit of research around that as well. Given some of the technology at the Ontario Tech University, they have a climate chamber. But that's it's kind of scary to know what's ahead, given what's going on today. So it's it'll be an issue for sure.
One of my passions is bridging the gap between research and real world care. How do we ensure that cutting edge research reaches the patients who need it the most?
So it's similar to what I said. I think including people with that lived experience is essential, and not just to be part of the studies as participants, but as paid members of the research team, part of the decision-making process on how that research is executed, especially for those, interventions or, treatments that impact the various factors like the triggers, and in creating solutions, because otherwise, if it isn't meaningful to the people that it's supposed to be meaningful to, and you don't get their feedback and advice and expertise, then it can't be applied back, and you won't get buy-in and stuff like that. So then, the research for research sake is great, but if you want to make an impact on people with asthma, then you need to have them as part of the team. And, some people are doing this well. I know in the UK, it's a requirement, and I think it needs to be as well. Here in Canada, for any research study, especially one involving patient outcomes, there needs to be someone with lived experience on the research team. Yeah.
I think that's so important. And even at discussions, webinars, workshops, symposiums, what have you, even at those events, I think it's important to have that patient perspective as well. And that really is why I do what I do. And I can't even count the number of times I've had physicians, healthcare personnel, whatever, come up to me afterwards and say how it was so refreshing to hear from the patient rather than just sit through one of those, typical symposiums and just see a bunch of stats on the board.
Yeah, absolutely. I think it was at the conference where we met, where there was a physician, but he was also an MP.
Yes.
And he says, yeah, well, your research is great and everything, but, get the person in front of you, and that's the real impact. And, we've seen that happen many times where it's the people that make the difference.
That's right. You need to, you do need to cater to kind of that emotional side of someone, because everyone has that emotional side, even people that work up in government. And those are the policymakers. Those are the people that we really need to tell our stories to.
Yeah, absolutely. Absolutely. I think that happened with, was it Ryan's Law, or was it with respect, there was a child who died from asthma in the schools, and they actually made a law around that. So that was just a perfect example of something where, that compassion comes in.
It's scary. 300 Canadians die per year in Canada due to direct asthma exacerbations. That's troubling for sure.
Yeah.
And any change that we can make, I think it's time that really these policymakers start really listening to us.
Yeah, for sure. Absolutely.
Pulmonary rehabilitation has been a growing area of interest for asthma care. Can you explain its role and potential benefits for people with asthma?
So I see this sort of as a spectrum for asthma care. Any exercise program is a benefit, full stop. Because it helps making the body more efficient when it comes to energy and oxygen consumption. It builds muscles, not just for, these ones and the walking ones, but for the breathing ones, like you have muscles that help you breathe as well. So when you are able to build up those muscles, just like if you were to do a race, if you were to encounter, let's say you have an exacerbation, because you've already built those muscles up, it becomes a little bit easier to recover as well. So definitely exercise, full stop, is of benefit. Asthma, it affects people across the lifespans, from kids all the way up to older adults. And it kind of has times of normality and then times of difficulty as well. So as long as a person knows their triggers and what to do in those difficult situations, so they have a good management plan, I think exercise should be part of that as well. If they're going to do something fairly vigorous, like you did, like you are doing, Josh, with respect to the running and everything, I do recommend consulting exercise experts along with the primary care physician or respirologist or whoever is sort of the main healthcare provider, because those exercise experts, they really know the physiology and things like that, and can sort of cater and individualize programs and also make it fairly safe. But otherwise, if you're not going to, if your goal isn't to do the Ironman or whatever, then, go out for a walk, yoga, what have you. It will benefit not just yourself, and bring a friend, because it'll benefit your friend as well. For the older and more severe asthma group, especially those with the overlapping syndrome, there are specific pulmonary rehab programs out there that are formal, that require doctor's referral and things like that. And these are the folks that would have problems with their shortness of breath, like doing simple activities, for example. So I highly recommend that they do a pulmonary rehab program. Now, the difficulty on that, which is probably another show altogether, is there's so few available across Canada. So if for the number of available programs for people who need them is less than 5%. And that's been like that for years, unfortunately. And I probably hear more about programs closing than I do opening up. But if you have that resource available, to seek them out. And there are virtual options available as well, because COVID allowed for that. But definitely an important part of the management for asthma.
That's great advice, and incredibly important as well to, like you said, listen to the doctors, make sure your asthma is under control before you engage, especially in rigorous exercise like myself.
Yeah.
But as well, there are experts in these fields too, like running, if that's something you're going to do. So consult them. Make sure you're doing it properly. Consult your physician. Make sure you can do it to begin with. I think that's important. Actually, we have a guest on next week. His name's Stetson, and I'm super excited to have that discussion with him. He's a running coach, and he's asthmatic as well. So he's learned how to cater his workout routine and his training for others when he is training college athletes to kind of his steps and what he does to take care of his asthma while he's engaging in cardiovascular exercise, which I think is great. So it'll be good to have him on and then discuss how you can do it safely.
Yeah, I know. Again, that's the perfect example of people with lived experience, right? You can look at all the research you want, but it probably won't be there. And B, they're just as, they're the evidence as well. And I know there's a few people out there. I know there's a gentleman in Australia. He has COPD. He needs oxygen, but he does Ironmans with oxygen on.
Wow.
So, when you sort of seek out advice from people like that, I think that's a really good idea as well.
So let's move on now to the role of respiratory therapists and education. Many people don't realize the critical role that respiratory therapists play in managing conditions like asthma. So can you talk a little bit about the impact RTs have on patient outcomes?
Yeah, so there is some research out there that shows that RT-led treatments compared to, say, physician-led treatments is just as good or even better when it comes to things like minimizing duration of respiratory life support or mechanical ventilation and how long a patient spends in the hospital. But there isn't as much strong evidence or research investigating the impact RTs have outside the hospital, because I'd say the majority of respiratory therapists actually practice inside the hospital, in acute situations. So like community care, asthma care, and things like that, there's sort of bips and bops of it out there, but not as much. There's lots of examples of the RT role in asthma care. So like certified respiratory educators, they help with the action plan development, education, including, medication use, they do follow-up care. So you'll see them doing the spirometries and pulmonary function testing and things like that. And if you were to just do even a search on the web, you'll see that there's different models of roles there. So as I had mentioned, like with, the running coach, that, we end up relying on other types of evidence, and that's sort of expertise. So people like yourself, people who coach other asthmatics and, or runs, does Ironman with oxygen. So we ended up relying on that, which is just as good as well when it comes to seeing how important, respiratory therapy or respiratory therapies are as well, until the research sort of catches up, because research always takes some time. But like research, there's always sort of good and bad and ugly of research, as you probably know. You sort of have to be careful as well when it comes to people evidence. There's sort of the good and the bad and the ugly of people providing that support and evidence as well. So it's, but it's out there. I think I may be a little biased being a respiratory therapist, but I know there's sort of a little bit of both research and, the anecdotal evidence as well.
I think they're incredibly important. And you mentioned CREs, certified respiratory educators as well. That's huge. And really my goal, what I'm trying to do today is I'm trying to get more CREs in every single emergency room. I think that is incredibly important. When I go into an emergency room and they check my oxygen saturation, it shows 96%. Yet I feel like I'm about to collapse. I know my lungs, and they tell me, your stats are fine. Go sit down. It's an 8-hour wait. That's an issue.
Yeah.
If we could have a CRE there, somebody that could assess me, somebody that could talk to me, somebody that really understands my lungs, I think that would be huge, because something terrible could happen, right?
Yep.
I shouldn't have to leave triage to go sit in the waiting room, to go out to my truck to take my nebulizer, because I don't think I'm going to make it to see the doctor. That's an issue. That's a very big issue.
Yeah, no, I actually encountered something similar back when I worked clinically. There was a gentleman who came in, waited too long to come in, I would imagine, and his oxygen was high, but I'm looking at him going, no, this guy is not okay. And, sure enough, you've probably had your blood gases drawn many times, right? So one of the things that comes up that doesn't get measured easily is the carbon dioxide level. And his carbon dioxide level was through the roof. It was insane. But because we don't have a oxygenation probe like we do for carbon dioxide, there are technologies now to do it. They, as you said, unless, I was a respiratory therapist, I could have that expertise. Otherwise, yeah, you're absolutely right. It's kind of scary.
I don't know if you know, do you know what Dr. Anton Hellman?
No.
He has a podcast. I just listened to it the other day, and he had said something in the podcast. He had said, people with asthma don't always present with wheeze. And it's when they don't have wheeze and they're in the emergency room that I'm nervous.
Yeah.
And he had another doctor on there that said that in situations like that, he, tells the patient to take their shirt off so he can actually watch them breathe. And it's the first time I've ever heard that. I've never had that done to myself, but that makes so much sense. And I wish kind of, everyone really thought that way. Unfortunately, I've been in, I'll just go to a walk-in clinic and I'll have the physician listen to my lungs and say, oh, but your lungs sound fine. Well, yeah, they sound fine, but I'm only using a quarter of its capacity to breathe right now.
Yeah.
Thought I would point that out.
No, it's funny because I mean, I've been a respiratory therapist for, over 25 years. And, we were taught the basics of, the lung, that's why I mentioned the respiratory muscles, because if you've probably heard that, right? Like if you see the muscles here working, and then, there's certain muscles where you're like, okay, that person's working really hard, because normally we're not using our respiratory muscles. It's very passive. And but when you're using them, then that they're working very, very hard with that. And then with kids, it's even more of an issue because there's, their chests are so flexible and everything. Mm-hmm. It becomes a little bit insane sometimes what they look like. It's almost like we need, the healthcare providers need a lesson on assessment, on basic assessment without equipment, like without,
right.
Bleep, 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 without those kind of things. It's just like, this is your patient, look at the person, kind of thing. So it's
like when we don't have the answer to a question, we're all too quick to look at our phones. Sometimes it's good to kind of think about it.
Yeah, for sure.
Asthma education is key to better management. What are some common misconceptions about asthma that you often come across?
Yeah, so I actually didn't mention this, but my son actually has asthma. And, he's been able to manage it for some time, not severe asthma. I guess one of the common misconceptions is that it's a minor condition, right? So people don't realize, and you had mentioned that, the mortality rate for people with asthma, that can be life-threatening. Mm-hmm. And I've seen this, working in an acute care environment. I think it's because unless you're family or close friends, you just usually see someone with asthma during their good times, you know what I mean? When they're not exacerbating or having a tough time. So I think that's why people think, asthma, that's nothing, So to me, that's a huge misconception. And then, the other one is, go ahead.
It's either one end of the spectrum or the other. It's either you can't do anything because you have asthma, or asthma's not that bad, get up. And like you said, you don't see these people that are having exacerbations because they're not going to be there. And I can relate to that. I mean, if you come to a house party, even if I'm the one hosting the party, if my asthma's bad or if I need my nebulizer, I'm upstairs taking it and I'm not showing my face until I feel better. So you just don't really understand what's going on.
Yeah, it's like sort of a silent illness.
It is, yeah. And I think, that's just more towards the stigma that really encapsulates asthma.
Yeah. And as you mentioned, it doesn't affect people in the same way, right? So, one person may wheeze. My son doesn't wheeze so much as he does cough, right? So when he has a trigger, he will cough more than he will. Then I'm like, you need to do this, this, and this kind of thing.
Yeah.
So, and it all depends on, the environment you live in and the genetics. And so everyone's sort of differently. So it doesn't always affect people in the same way. I think that's the other thing as well.
If you could change one thing about how asthma is taught or understood, whether by the public, patients, or even healthcare providers, what would it be?
So I would say communication across all sectors with the person with asthma in the center. right? So this means everybody, family, like the person, family doctor, respiratory therapist, CREs, the hospital, community care, schools, government, etc., that they have access to the same information in the same place. So that, if one person is seeing you, they're contributing to this one communication base. So then if something's happening at school, the school says, oh, well, I could see that they were hospitalized on this date. Or if, the funding bodies like the government are able to see, different, more like as a group, oh, I see. The reason why there was, a large blip in funding was because it's that time of year and we don't have enough support for medications or something. So I think if we were to have a common place, so you're not constantly telling the same story over and over again to different people, but that you're able to integrate all of that together, it kind of helps provide a holistic view. So that would be, it sounds like it's a fairly large thing, but that would be a great thing to change when it comes to that kind of care.
Something we can certainly work towards anyways.
Yeah, for sure.
So I'd like to move on now to the future of asthma care. Your research spans a wide range of respiratory topics. Are there any emerging therapies or technologies that you know of that excite you the most?
I had already mentioned the asthma biologics. I think there already has been studies that show benefits, particularly for adults, but there's still a few unknowns about it. So, for example, do people need to stay on them for the rest of their life in order for it to be benefit, or can they be weaned off? And does the body kind of take over because these biologics have helped the body produce, these antibodies? We don't know, right? So these are all huge question marks. So I think, that kind of therapy, a specific medication, and what can be done with that, I think is definitely an emerging therapy. I have seen, and I mentioned this at the panel, an interesting diagnostic technology where you can see the inside of the lungs in real time, but it's radiation-free and non-invasive. So if you put a belt on, like, when you wear those belts when you're running or whatever, it's basically just a belt that gets put on. And then as you breathe, you can see the lungs inflate and deflate and whatnot. So in the case of when you were talking about limited lung function, if you have a really bad exacerbation, sure, with a stethoscope, it sounds okay. But then if you were to stick this on you and think, okay, look at how much you're missing there on this machine. So it's called electronic impedance technology, or EIT. At the moment, it's being used fairly frequently in the critical care environment in mechanically ventilated patients. Okay. But it's going more and more outside the unit, and I could see it being refined for environments outside the hospital. Can you imagine? It'd be great. Like, in addition to spirometry, you just have to breathe. You just put a belt on you and you're just breathing. I think that would be really cool to see. And then I'd say because I'm an RT, maybe the RT profession will start to become a degree entry to practice. Right now it's a diploma, or an advanced practice RT in whatever area. I know the US has something like this, where they can diagnose and treat patients with various cardiopulmonary disorders. At the moment, they're kind of like physician extenders, but eventually I would see them becoming independent, like nurse practitioners are, for example. And I think this, because we had mentioned about the shortage, this would help the human resources shortage, because we don't have to always rely on the physician to do it or on the nurse practitioner to do it. We can utilize the respiratory therapy scope of practice as well. So it isn't just always about needing more doctors and nurses. So I think that's another emerging sort of therapy, I guess you could say, as we move forward.
Right. Incentivizing really what's already there.
Yeah.
It's a great idea. And that belt you were talking about too, I can see the applications for it already. As I mentioned before, the issue with, just getting my oxygen saturation done in triage at a hospital. Well, what if that's incorporated into that plan as well? That's terrific.
Yeah. And like I said, you see it in real time. So whatever you do, you can see if it works or not right there and then. So I think that's a cool thing that we'll see more and more of.
We're seeing a push for more personalized medicine in healthcare. How do you see this trend impacting asthma treatment in the coming years?
Yeah, so we touched on this a little bit with the AI, and I know this is a top priority for hospitals and universities and research organizations. I feel like this year, 2025, everyone's redoing their strategic plans for some reason for the next 5 years. And personalized medicine is definitely one of the biggest ones. There's been work done on to the genetic side of things with respect to targeted drug therapy like cancer chemotherapies. But for asthma treatments, I see this for medication. We already see this with the biologics, but even with the overall management, I'd mentioned, the AI can, put together based on everyone's, not just the medical history and physical history, but also the social history as well, I think is very important to put in there to see, the sort of different menu of items. So yeah, I definitely see this. Like I said, I think a couple of weeks ago, I went to the sick kids. They were going to launch their strategic plan, and they're like, we want to make sure that things are individualized for the patient. So it's on the radar. And even today, they just released an AI mechanism as well at the hospital. So it's I think definitely we'll see this in the next 5 years really, really sort of flourish.
That's great. I'm excited to see more of that.
Yeah.
With the rise of digital health tools and remote care, how do you think technology will shape the future of respiratory therapy and asthma management? I know we kind of talked on that a little bit, so I guess just to more expand in that realm.
Yeah, well, there's a few platforms that do this already, and a lot of them became important during COVID because we had to be remote and everything like that. So I know there's a study ongoing where they actually the device is already out there, but it's like a tablet, and then you can put adjuncts to it. So you could put a blood pressure cuff or an oximeter probe for oxygen. And I know there's some sort of peak flow and spirometry technologies that could probably be integrated as well. Well, the evidence isn't quite clear on that yet because spirometry isn't just about the technology, it's about the technique as well. But I think that will come with time, like that evidence on remote spirometry will come with time. So the beauty of that, not just the technology, is the tablet is connected to the person's healthcare team. So there's always sort of a two-way communication. So during, let's say, during sort of normal times, quote unquote, the person's assessing themselves on a daily basis. So people do this all the time with their blood pressures and, blood glucose or something like that. And so if something troublesome comes up during that time, let's say, the oxygenation is falling, the blood pressure is going up, what's going on? It could be like a notification for both the person and for the healthcare team. So then the healthcare team is like, what's going on with Josh today? Mm-hmm. So it ends up being a proactive, let's get in touch with Josh to see how he's doing, what's going on, how is he feeling kind of thing. And that technology is already out there in the later testing phases. So I think it's something that, can be accessed today. But again, limited by, into whatever region decides they want to do that. But you can see that would be, much more efficient as well to be proactive, and also plays into that precision medicine question as well.
That's great, because I can tell you one thing, that asthmatics do get complacent. I get complacent. And I mean, oftentimes I take my inhaler when it's too late. So if we can have that proactive asthma care management, telling us when we should probably consider taking our inhaler, when something might be happening inside of our lungs, I see that just being nothing but beneficial. I'm excited to see more of that.
Yeah. And not just a device, but a person on the end and going,
yeah,
better take your puffer, better do your
Right. Someone breathing down your neck. You don't always have
right.
Mom around to do it for you.
That's right.
So I'd like to move a little bit more into your career. So throughout your career, is there any particular patient story or moment that has stuck with you and reinforced your passion? I'm going to repeat that. Sorry. So I'd like to move on a little bit more and talk about your career. Throughout your career, is there a particular patient story or moment that has stuck with you and reinforced your passion for this work?
So usually the stories that have stuck with me have little to do with the actual respiratory therapy part. For one of my studies, I think I mentioned I went to a person's home. So I spent a lot of time in their homes collecting data and things like that. And this allowed me to talk with them and get to know them a lot more. And I found that some of them has like amazing life stories. Like I couldn't believe it. It's like they should be a movie or something. But I got a picture of how they got to where they were, and understand the motivations and come up with solutions that were more suited towards them and give me some ideas for the research. I mean, talk about precision medicine right there. I learned very earlier on that I needed to listen to the patient, both with my eyes and ears. So, because I remember when I worked in critical care, I was working in the emergency department. A patient with COPD came in, and she was in a lot of distress. But because I had experience with people, who have COPD and had exacerbations in the home-based research, I kind of stopped and listened, and had a conversation with her. And I found that was just as helpful as, the bronchodilator therapy I was giving her, because she was like, oh, someone who understands, like, this isn't, I'm not just in here because I'm, being a burden or whatever. This is a real issue. So, taking the time to do that, I think, very early on, I realized that makes a huge difference. And it isn't just about the medicine that you give.
It's easy to feel alone and stuck when you have a condition that is not well treated. And you begin to think that that's the norm. So if you're listening to this podcast and you're thinking, well, I have severe asthma, I've never been able to go, 2 hours without taking my inhaler. I have been there. It's certainly not the norm. The norm is now, taking my inhaled corticosteroid on a regular basis, unfortunately, but not really needing to solely refer back to my emergency inhaler, which is huge. For me, that is what control looks like.
Yeah. Yeah. No, it's funny because when I'm doing a lot of my research, of course, I try to have as many study participants as possible. But during that journey, I often am having a conversation with them, whether they want to be in the study or not. And I don't know how many times, too many times, it frustrates me that they don't have enough care. Like they don't have a respirologist, or they don't realize there's a pulmonary rehab program, or that there's resources on, the Lung Health Foundation website. And I think, oh my gosh, like it doesn't take much, but it frustrates me. But, because they don't know what they don't know where to go for that information. And that, yeah. And I think we need to sort of step back and say, okay, let's take a listen to this. And I think that's where I know there's the family doctor, but having a team, like a family health team or a primary care team, is essential because, yeah, you have your doctor to prescribe and whatnot, but then you have your CRE and then you have your nurse practitioners and the lab people, so that they all are optimizing their time. So it isn't just the doctor that has to do everything, right?
I couldn't agree more. It's always felt like I was just going in to be prescribed more meds, getting more meds put down my throat, really, when I think 50% of it, or maybe even 70% of it, in my case, truly how I feel today, is in things like education, like CREs, having them give you that information, and not just yourself as well, but your caregiver, so your family, your mom, your dad, what have you, educating them as well, because that there can really keep a patient out of the hospital room. And one big thing for me growing up, I grew up in a house that was built in 1867. It was old. We had dust mites, we had farm animals, we had cats, we had dogs, all that. Those are all triggers. And I know that well now. But at the time, I didn't really know that. And, I would go into the hospital room and I would be admitted. I would stay in the hospital for 1 week, 2 weeks, whatever it was. And then I would feel great. The last 2 days, I would feel great. And they'd say, okay, cool, we're good to discharge you back home. I'd go back home and the same thing would happen. That vicious cycle would continue. I would get sick. I would have an exacerbation. I would go 3, 4, 5 days, just constantly sucking on my inhaler and my nebulizer until finally I said, Mom, I need to go in. And I would go back in again. And then I would use up those valuable healthcare resources. When I truly feel if I was educated properly the first time, if we were educated properly, I wouldn't have been such a burden on the healthcare system.
Yeah. And that's why I always think innovation is when, a province or a country figures out how to do it, widely. because, when you think about hospital care, the funding is different than community care. It's almost like they're siloed and they don't talk to each other. Yes, we're saving money in community, but they don't care because, the hospital budget is expanding, or vice versa. And I think that needs to change. And if that changes, that approach will change, right? So if there's more focus on prevention, then I think, but we need to see the whole picture, right? The whole picture, not be siloed with stuff like that. But yeah, it's, yeah.
The work you do requires persistence and dedication. What keeps you motivated?
Definitely the people living with the lung disease, like yourself, Josh. The healthcare providers doing their day-to-day practice because, they're putting themselves out there as well. I see them working very, very hard and burning out. And I have a large teaching component in my job as well. So when I see future healthcare providers, students having those eureka moments, I know I'm trying to instill in them the importance of, when they go to practice. So that definitely keeps me motivated as I go through.
If you could give one piece of advice to individuals living with asthma, something they might not often hear, what would it be?
So this kind of reminds me of work done by Dr. Seow and Dr. Winemaker in the McMaster Hamilton area. And they describe these things called 7 keys for navigating a life-changing diagnosis. Their focus is on a palliative care approach, but, their 7 keys can be applied to individuals living with asthma because asthma is a life-changing diagnosis, right? So that's the way they approach it. They don't approach it like, palliative care. They approach it to, this is how you should, these are some of the things you can do if you get a life-changing diagnosis. And their overall message is to empower yourself when managing your healthcare journey. Don't take a step back, ask questions and repeat and repeat and repeat until you get that management plan or what have you that suits, your life kind of thing. Their emphasis on, you can take this path, or you can take this path, right? So oftentimes you'll find physicians are, they know their thing, they know their expertise. So they'll only recommend this path, but they're unaware of the other paths, but they're out there. But oftentimes it's up to the person to empower themselves to ask those questions, especially if they're uncomfortable with the path that the physician is recommending, right? So if there would be one piece of advice is to empower yourselves with those questions, with your goal in mind, and stick with it and don't back down. Or if you have trouble with that yourself, bring in someone that will help you do that to advocate for you as well. So, yeah.
That's great advice. So move on now to closing. For listeners who want to take more of an active role in their asthma care, what's the best first step?
So I'd say, their primary care team is a good start because they're usually the ones that refer and everything like that. And it doesn't have to be a physician. It could be the nurse practitioner or a CRE or somebody like that if you're able to access a team. And so hopefully that will start the process of getting additional care and advanced care within the environment as well. But in addition to that, because you had mentioned, Josh, getting a respirologist is difficult in more rural areas. Resources like Asthma Canada, Lung Health Foundation, Canadian Lung Association, Canadian Thoracic Society. So they have a lot of good, strong, and rigorous evidence-based information that people can look into while they're waiting. And some of these organizations always also have support. So the Lung Health Foundation has phone support and peer support and things like that you could possibly access as well. That doesn't need a physician referral. And then, sort of related to that is talk to someone who has asthma, especially one who has a lot of experience like yourself, Josh, right? Because they probably have navigated the system. They know, some advice as to how to get to where they're going, other resources, and then other people who has asthma too. It's kind of like a snowball effect. So that's where I'd say it would be. Well, I guess it's more than a first step. It's sort of the first steps for people who have asthma.
That's a good thing to point out in regards to the non-for-profits that are out there as well. Asthma Canada, for one, they've just celebrated their 50th anniversary, which is terrific. Lung Health Foundation, double that. And you mentioned Thoracic Society. And they do have their helplines, again, that will connect you to a CRE. I know Asthma Canada, they have the asthma helpline. I've been through with one of the nurses, and she's led me through the process of it before. And it's really super easy. If you have a question at all, anything at all, it really doesn't matter. They have the specialists and the connections that they could hook you up with to answer your question. So I strongly do suggest checking out asthma.ca if you are an asthma patient or a caregiver and would like a little bit more information.
Yeah, absolutely. Yeah.
Where can people learn more about your research and the work that you're doing?
Yeah, so a good place to start is the Ontario Tech University website, and then you could just search my name. I'm also on a crazy amount of social media as well. So, the usuals, Facebook and Blue Sky and Twitter and LinkedIn. And oftentimes I'll actually post about some of the research I'm doing if people are interested in taking part. I am hoping to do some more research in that climate chamber, perhaps in late summer as well. And that'll all always be on my social media as well. So yeah, and get in touch.
I'll be sure to leave those links and as well your mentions in the show notes below so people can follow you. So we'll move on now to our final question, a question that I ask all of our guests at the end of the show. So whether you have asthma or not, every breath we take is a gift, a reminder of our resilience, our drive to keep going, and our power to define our own limits. With a single breath, you have the potential to move mountains and change the world. So with that in mind, again, I have one final question for you. If you had only one last breath, but with it the power to influence the world, what would your message be?
I would say to listen and understand before acting, because it sounds simple, not always easy, but this will drive progress forward, and it's rewarding to everybody, to yourself and to the people that you're working with.
Dr. Nonoyama, this has been an incredible conversation. Your dedication to advancing respiratory care and ensuring that research translates into real-world impact is truly inspiring. Thank you for sharing your insights and for all the work you do to improve the lives of people with asthma and other chronic respiratory conditions. For everyone listening, if you found value in today's episode, please take a moment to subscribe, share it with someone who needs to hear it, and leave a review. And if you want to learn a little bit more about Dr. Nonoyama's research and work, check out the show notes for all the links. Remember, breathing isn't just survival, it's a statement, a reminder that we're here, that we're capable, and that we can keep pushing forward. So until next time, keep breathing deep, keep pushing forward, and never let anything hold you back.
Thank you for listening to Beyond the Wheeze. If you enjoyed this episode, don't forget to subscribe and share. Follow us on Instagram at Beyond the Wheeze and or follow me at the Asthma Runner for more updates. Keep breathing strong and remember, your potential has no limits. Until next time.